and after this presentation we can certainly chat. I'll be here for a little bit, and or email me. I'll be happy to talk more about it or send a picture. But I think, and thank you, I really appreciate for the question. It really helps to fill the time. I think now would be a great time to start. And so I give you plastic surgery complications and how we can minimize them. And off we go. So I'm going to break this talk down into two sections. There's a lot of ways you could go with this, but I chose to take a general approach, meaning I'm going to talk about the surgical and non-surgical adverse events in general that could apply to any procedure, surgical or non-surgical, or even topicals like lasers, chemical peels, things like that. So we're going to talk about the general adverse events. I could have gone individually, surgery by surgery, but that would take a long time, and I feel like I'd miss something. So we're gonna approach it this way. And at any point, if there's any questions, please just go ahead and jump in, because I would love to answer specific questions. So so first off, I wanted to start with a listing of the most common procedures in the United States. This varies a little bit year to year. I think this was the statistics from 2020, but every year there's a survey done and we track them. So on the left side, there's a silhouette of a woman, the right side, silhouette of a man. I guess we can still broadly use those categories. So on the left side, with female having surgery, breast augmentation still the #1 procedure in the United States. It typically is, followed by liposuction. Those are pretty consistent. Blepharoplasty, which is eyelid surgery, rhinoplasty, nose surgery, abdominoplasty, a tummy tuck, and breast lift. Those are pretty consistently my most common surgeries as well for my patients. On the male side, you have rhinoplasty, blepharoplasty, liposuction, breast reduction, actually very common for men who have abnormal breast development, hair transplantation, and dermabrasion. And I think those are pretty consistent in my experience as well. So just have an idea of where these are done. And so we'll start with surgical adverse events. And I love this quote. I don't have anybody to attribute it to, because I think, like a lot of things in surgery, it goes back hundreds of years. But I was taught in my training, and I hold fast, that there's no problem that can't be made worse with a little more surgery. And it's funny, but it's true. So when things don't go exactly as planned, it's often best to use our brains and think about what we're going to do before we jump in and do a little more surgery. So I hope that made you chuckle. It always makes me laugh because there's truth to it. And so this diagram is going to just kind of list pictorially the general organ systems that could be affected in surgery, and then I'm going to get into the individual ones that are specific to plastic surgery that I do. But we'll talk about some of the neurologic, the surgical, the pulmonary, and the systemic mostly. So let's move on, and let's get right in there with a, we'll do pulmonary first. So pulmonary is really talking about a DVT, which is a deep vein thrombosis, which is a clot that forms in one of the deep veins in our body. It's typically in an extremity, like an arm or a leg. But I always tell patients, any pain that you experience outside of an area that you had surgery on, please let me know right away. So for example, if we had breast surgery and it hurts in your calf or your thigh, I should really know about that right away. Or if you had abdominal surgery and it hurts in your arm, I should know that right away, because that can be indicative of a blood clot forming in your leg or your extremity or wherever, but it can be other places. And so the best thing to do with a DVT is to avoid it. And so there are risk factors that are enumerated by the Cappuccino risk assessment score. And although there are 30 or 40 factors, the most common one that we see, the common ones, would be smoking, birth control medication, obesity, age above 61, any recent injuries or trauma, or a history of blood clots or clotting disorders, and then major surgery over 45 minutes, which is most surgery that we do in cosmetic surgery. So the idea is to try to eliminate as many of those that is possible. So if we are on birth control, we might have you stop. If you smoke, you have to stop. And then once we reduce those factors as far as we can, if we feel that it's a safe procedure to continue with, then we would do things like SCDs, which are sequential compression devices. Those are the boots, we call them. They put on your calves, and they intermittently inflate and deflate and essentially massage the calf muscle, because as we're walking around, our calf muscles are flexing and pumping and assisting that blood to be pushed back up toward the heart. Even when we sleep, we move around, but under anesthesia, we can't move that for ourselves. This aids in that and doesn't let the blood pool and coagulate and form a clot. And then, of course, we ask patients to ambulate frequently after surgery, and if the risk factors are high enough, often I'll give a dose of Lovenox, which is an anticoagulation medication. So that's DVT. This is probably the scariest one, so I want to get it out there and get it out of the way. It is also, however, fairly uncommon, but the one you don't ever want to miss, and you always want to make sure we're doing everything we can to minimize this risk. If someone was to have one, we would immediately get an ultrasound of that extremity or the part that hurts, and if we identify one, we would give anticoagulant medications to stop the propagation or even break up that clot before it could travel to the lungs and cause more damage. So we'll switch gears a little bit now, and we're going to talk about something that is much less dangerous than a pulmonary embolus, but much more common. And that's syncope, fainting or passing out. And this can be very scary to a person who has just had surgery, or more often the family member who is tasked with taking care of that person. But it actually isn't very dangerous, of course, unless you hit your head and hurt yourself, and it's transient. But again, as I said, it can be very scary. There are two types of syncope or fainting that we see after surgery typically. One is orthostatic hypotension, which simply is a drop in the blood pressure because we stand up quickly and the blood can't rush back to our head fast enough, and we get lightheaded and we pass out. And we often see that with an increased heart rate, and it can be exacerbated by dehydration, which is one of the things that we can see after larger surgeries. The other one, which we can sometimes see, is what we term vasovagal, and this is where somebody will essentially get lightheaded and woozy, and they feel hot, and their blood pressure drops, and their heart rate drops, and it's usually caused by an emotional or mental imagery trigger. So it could be pain, it could be the sight of blood, or the sight of a drainage tube, or the thought of a needle. This happens very often in my office, probably once a week, and it often is just associated with somebody thinking about or being apprehensive about a procedure, and it's very common. And again, when you're in the office and you're in a chair, you're laying down, so I don't worry at all. The one piece of advice I could give you or a family member, it's just good to know, if you feel lightheaded for any reason, or you feel hot or sweaty, or like the tunnel is moving in on you, get down quickly. Lay down. It's happened to me once, so I can tell you, I can empathize, and I can speak from experience that I got vasovagal once, and you're not thinking very clearly, so I wasn't sure exactly what was happening to me, and when I realized it, I immediately sat down on the floor so I didn't fall and hit my head. At any rate, if this ever happens to you or a loved one, my advice, of course, is to first make sure the person hasn't hurt themselves. Check their pulse, check their vitals, make sure they are conscious. They should come around very quickly. Usually it's in a matter of seconds. If not, of course, call EMS. But if people do come back to consciousness and you're just not sure what's going on, contact your surgeon. I would much rather you text me or call me than take an unnecessary trip back to the hospital right after surgery. So that's what I have to say about fainting or passing out. And again, if anybody has any questions, if you're just joining in, we're talking about surgical complications, so go ahead and type your questions in and I will answer them if there's a specific question about surgery or anything plastic surgery complication related. Another very common problem that we see with surgery is called a seroma, and a seroma is essentially just a collection of fluid, clear fluid, under the skin typically. So it's usually after a surgery that has a flap, like a tummy tuck or a thigh lift or an arm lift, or even sometimes breast surgery. And we've gotten much better over the years as we've maintained better techniques and post-operative regimens to diminish the occurrence of seromas. I don't see them that frequently. Typically we've used drainage tubes to remove that fluid while the skin heals down, but lately with a lot of surgeries, like a tummy tuck for example, I've stopped using drains, and a lot of the tummy tucks I do are drainless, and yet we have not seen an increase in seroma. So technique can certainly help, post-operative compression can help, But more importantly, if we do have a postoperative seroma and it's large enough that it feels like a fluid wave under your skin, then the treatment is drainage. And often we'll drain it with a needle, and if it comes back, then we'll put a drain in. A hematoma is similar to a seroma in that it's a fluid collection underneath the skin. However, it's blood, and it could be from bleeding that occurred after the end of the surgical procedure. We try to have everything what we call hemostatic, or not bleeding, but after surgery sometimes bleeding can start, and if that happens, a collection of blood forms, and we would want to drain that too. So that's another surgical site issue. Now this one's a little scarier looking, but often winds up being just fine, and this is skin necrosis and wound dehiscence. And I'll tell you what those mean if you don't already know. In the picture on the top, you'll see a little black patch of eschar, or dead skin as we call it. And this is essentially an area of skin that after surgery did not receive enough blood supply and it died. We see this sometimes with, again, surgeries that have flaps, like abdominal surgery, by arm, especially if it's under tension or the patient has some underlying healing issue. And while it looks terrible, with proper wound care and attention, it heals almost imperceptibly most of the time, even though you wouldn't believe it to look at the picture. But skin necrosis will then sometimes lead to wound dehiscence. Not always, but sometimes, depending how deep the loss of skin is. And the wound dehiscence is just an opening of the incision, or a separation of the edges. And that will heal up from the bottom up. Sometimes we assist that with dressing changes or a negative pressure wound vac system. Sometimes it will just heal with minimal help. And of course, you're going to hear this again, increased risks with smoking and diabetes, obesity, and then infection, seroma, which we talked about, and then underlying medical issues like anemia, malnutrition, diabetes. I think we mentioned that. So these are common, but not that common. And this can happen with any kind of surgery, not just plastic surgery. I want you to put it in perspective. I don't see this every week or every month. I see this a couple times a year. So not that crazy common. Cellulitis is a bacterial infection of the skin, typically after surgical procedure, but it could be something as simple as a bug bite. Anything that can break the skin's barrier function and allow bacteria in can cause it. That's why we see it after a scratch or a bug bite or a minor injury, because our skin has a lot of bacteria on it. Now, the advantage we have going into surgery is that we cleanse the skin with an antiseptic, and we use aseptic technique in the OR. So it's pretty rare, but when it does happen, often it will look like this: red, hot, swollen. The reason that it's marked out in this picture with a pen is because we want to know exactly where it is at the moment in time we examine it and see if that redness is regressing and the cellulitis is resolving, or if it's going beyond the boundaries. And that's one of the ways that we help to measure whether our treatment, which is typically antibiotics, is working. SSI is a term that we use frequently in medicine, and it means surgical site infections. And again, the same risk factors that I mentioned before apply here as well. I know this isn't super exciting, but I want you to just be aware. That's why we're talking about it. I'm going to be pretty brief with this one because it is super rare. I've only heard of it happening one time. Thank God it wasn't my patient. But essentially, when we're doing abdominal wall surgery, that bowel is right under a very thin layer of connective tissue. And it's easy to puncture abdominal organs with a needle, or this could happen with liposuction as well, which is one of the reasons that board-certified plastic surgeons like myself take great care to make sure there isn't an inherent hernia or abdominal wall weakness when we are performing liposuction. Before we do that, we always want to do a good exam of the abdominal wall to make sure that we don't have a weakness and could penetrate it. So needless to say, this would be really bad, and it's also really rare, so that's good. And just a couple more here. Local anesthesia toxicity is something that you might not think about, but something that we think about with every case we do. And essentially, we use two different local anesthetics: lidocaine, which is shorter acting, and marcaine, which is longer acting. They can be combined. They work differently. They're metabolized differently in the body. However, overdose can be fatal. So we are very careful. It's based on body weight, and we know it's different for we're doing minor procedures like a mole removal or a local procedure like a mini facelift versus liposuction where we're using larger dilute amounts. But it's one of those things that you should be aware of. The mild symptoms could be ringing in the ears or a metallic taste in the mouth. Those are very early warning signs. Again, I have not seen this in my practice in 15 years, not even the mildest. So again, adhering to those guidelines will keep us safe, but we should also know what those symptoms are and what they can progress to, and have an appropriate rescue agent in the office and the place where we operate, which of course I do. But again, you should just be aware of this. This is a factor that can come into play because we use a lot of local anesthesia as plastic surgeons. Okay, so that kind of is an overview of the surgical problems that can happen, but plastic surgery, specifically cosmetic surgery, can have non-surgical adverse events that are actually less well described, not spoken about often, and can be equally devastating to patients. And after a long time in practice, we have seen probably all of it, and we have a good idea of how to avoid and help patients cope with this. I just like this quote. It's a funny one. She got her looks from her father. He's a plastic surgeon. Groucho Marx, classic comedy. So yeah, just a little bit of levity in there for you. So we're moving from the surgical type events to emotional events, and disappointment is something that is a real challenge and a burden for both patient and the physician. And this can be for a number of reasons, but often it's because the results aren't what patients expected them to be, or they just have an unrealistic expectation of what the results should be. And this is what I call an expectation-reality mismatch, and I try as hard as I can to make sure patients understand what things are going to look like and what they can expect. And often this is the result of, I think, an inadequate consultation. So I take this very personally and try to change my processes every time this happens, and it's fortunately pretty rare at this point in my career, but I did experience some of it earlier on, and we don't want anyone to be disappointed for any reason. And it can also be a physical outcome, but lack of a social expectation. So let's say the surgery goes really well, and the eyes look great, or the nose looks great, but that person doesn't see increased attention. Maybe they're single or newly separated, and they're back on the dating scene, or I see people who are feeling that ageism could be against them in the job market. They want to look younger, and maybe they don't get that job opportunity they were looking for. So even if I do my job and the outcome is expected, sometimes people are still disappointed, and it's just something that I take into account when I am doing a consultation. And so how do we avoid disappointment? Well, that's the question, isn't it? So how I do it really is I spend a lot of time with patients in the initial consultation. For example, a breast augmentation consultation easily takes me an hour and 15 minutes, sometimes an hour and a half. And, it's almost to the point where I feel like patients just can't listen to me anymore or talk to me anymore because it's a long time. But one of the tools that I think is best is showing before and afters of results typical of the surgery that we're planning for the patient that I'm seeing. And after a number of years and doing hundreds and thousands of surgeries, we do have a pretty good catalog of before and after photos, and I can usually show someone a patient that looks similar to them to give them an idea of what realistic expectations should be. And then the flip side is I really like patients to show me photos, and some surgeons don't care for that for whatever reason, but I love it when patients bring me in photos because I want to know what they think is an outcome that they like. And then I can either say, like, yes, I think that is a good outcome, I think it's reasonable, and we should aim for it, or I could say, I don't think that's possible for you for whatever reason. Your anatomy isn't favorable, I don't have that specific skill set, and try to help them understand if it's possible, and if it isn't possible, why. And it's a great way to try to avoid that expectation, reality, outcome mismatch. First thing we learn in medical school, listen to the patient. They're going to tell you what the problem is, and this is completely true here. So a lot of times I'll just spend the first 5 or 10 minutes just talking to get to know the person. Tell me about your family and your friends and your life and your interests, and your exercise routines and your diet. I just want to get a sense of who you are and what your goals and expectations are. It helps me to steer people in the right direction. And then during that time, I mean, patients are getting to know me. They want to know what I'm like, and they want to know what my credentials are and my skills are and my outcomes are. But I'm also interviewing them because I want to make sure that they are good candidates for cosmetic surgery, and not everybody is. And it's a difficult conversation, but I can sometimes say, I don't think cosmetic surgery is right for you. And then I'll be honest with them and say, I'm just not the right surgeon, but let me recommend somebody who is, or it's just not right for you in general. And hopefully people listen to me, because what we want is healthy, happy, satisfied patients with good outcomes. Body dysmorphic disorder is a condition that you may have heard of. It does get a little bit of publicity now. And essentially, like this cartoon shows, where we see a ideally shaped female figure looking into the mirror and seeing a less than ideal shape looking back at them. And that's a very good description from what I've been told by patients who have suffered from it and recovered and have insight to the condition. But essentially, it's a fixation on a part of the body or a minor detail or minor problem that the patient will then disproportionately blow out of proportion to the point of delusion, where it's what they fixate on, and they can almost perceive it as disfigurement. Plastic surgery is not a good idea in patients who have body dysmorphic disorder. Even if there's a real problem, a real physical cosmetic anomaly, often correcting that won't solve the problem, because it could trigger a new issue or concern. We fix the eyes and now the nose doesn't fit, or it can exacerbate it in their eyes. So these are very challenging patients, and it's my job to identify them, and once I identify them, try to help them. It's been my experience, I've seen a few cases, true cases over the years, that the best way that I found to help these patients is to just establish a very good rapport and trust. And they tend to be very forthcoming and honest and trustworthy patients. I have several in my practice, and it's been my personal policy to try to protect them from maybe other surgeons who might not identify the body dysmorphic disorder, or maybe wouldn't have the highest of standards for ethics, and ultimately they would be miserable and the patient would be miserable. So often I try to keep these patients in my practice and do the most minor things we can to help them to feel better, but not make major changes. So that's my own personal take on it, but I really do try to tread exceptionally carefully with these patients. Something that you might not think about, but I have seen, is how cosmetic surgery can cause tension with spouses or significant others or partners who might not agree with their desire to have cosmetic surgery. The common misconception is that it's often the partner encouraging the patient to have surgery. They want them to get a procedure done, so they will look a certain way. But in my experience, that has been the overwhelming minority of the cases, and typically it's the reverse, where the partner really does not want the patient to have surgery. And it's kind of sweet. They just love them how they are, and they love exactly how they look, and they don't want them to change. I understand that as a husband. But sometimes they don't understand their motivations, especially when the female is the patient, the male is the partner. And sometimes there can be insecurity issues, and they think that they want to look for a different boyfriend or partner, or sometimes there's underlying insecurities where they think they're going to look better, and so it can be difficult. And I think it's important to have the not consent, but the agreements about the procedure. And I see this a lot with people who have had bariatric surgery, where there's a couple and they're both obese, and one decides they're gonna take the plunge, they're really gonna lose weight, and they do, and the other person doesn't, and it causes a lot of tension. I've seen more than a few marriages split up over that, and it's really sad. But again, these are things I see from the outside, and I try to help people to avoid these concerns and these problems. Post-procedure depression is something that's really more common than people talk about. My staff, my office, we are all very aware of the things that can cause depression, how to avoid them, and I'll just walk you through a couple. So any surgery is stressful. I've had surgery myself. I've had shoulder surgery. I've had cosmetic surgery. So I can appreciate that even for someone in the field, it can be stressful emotionally and of course physically with the recovery process, having to rely on other people for a while. So these things can add to depression. With cosmetic surgery, sometimes the results take up to a year to see, even longer in the case of rhinoplasty. And so we of course try to prepare people for that, but sometimes people are disappointed when they don't see those results that quickly, and that can add to some depression. Bruising that may or may not be expected can really be frustrating and socially limiting for people. So those are all common reasons. Pain after surgery, although we do a great job managing pain, sometimes that can just make somebody depressed. But depression specifically after cosmetic surgery, plastic surgery, bariatric surgery, and cardiac surgery, there's a higher incidence of that. And there are many factors that lead to that, and there are many theories. We typically see it from day 3 to day 7 after the procedure, and there are some really fascinating physiologic concepts that I think about, like the suppression of the adrenal cortical axis, where we're putting out essentially all of these fight or flight hormones after surgery, and we are trying to get our body ready to heal. And then when they drop off, there's almost like a drop in mood as well. So these things are expected, and the best way to minimize these is through education. So myself and my staff, we all try to have a thorough explanation of what to expect, and then frequent check-ins. And that patients really have reported back to us that helps so much, that we've explained to them what was going to happen. We support them during the post-op period. I try to speak to all my patients the night of surgery. My staff calls the next day. The center who we operated with calls the next day. And we just try to stay in touch as much as we can until we get through that first initial period. To me, that's been very effective. Now, on the flip side, we'll end on a positive note here. And the positive note is that in general, people do very well and are happy with their surgery and do have improved self-esteem and confidence. A fairly large, well-regarded study in 2006 showed that 31% of depressed patients, going into surgery depressed, who had plastic surgery were able to discontinue their medications for depression within 6 months of surgery. It's pretty significant. So we do know that in general we have a positive impact and effect on people's life. I know it myself after having procedures that I've had done, seen it countless times with my patients, that there's just this improved self-image, which we then reflect to the world. And when we reflect a happier, more positive image to the world, we see that mirrored back to us, and so it propagates itself. Self-perceptions of attractiveness, they do really relate strongly to an overall feeling of happiness. We face it, we do feel better when we have our hair done, if we have makeup on, when we have new clothes on, we tend to feel happier and better. And I'd be lying if I told you that that wasn't the majority of the reason that I do cosmetic surgery for patients. And I have to remember that the overwhelming majority of my patients come back sooner or later after surgery and are genuinely appreciative and thankful and say, "Thank you so much, you changed my life, I feel so much better, I'm so much happier." And it means a lot to me, but it's human nature, and especially when you're a perfectionist like I am, even if it's a very small percentage of patients, 1 or 2%, who are unhappy or have untoward outcomes or real complications. And so, the old 80-20 rule, I'll wind up spending 80% of my time and energy, on those, not 20%, but the 1 or 2% of patients who have problems. But I think that's how it has to be. When everything's going well, they don't need as much attention. But when things go wrong, that's when you really need your surgeon and their staff and their office to be in your corner and be your advocate. And the one thing that I have found over the years, and it was advice I was given a long time ago, when the patient has a problem, run toward it. You want to be involved from the beginning, whether it's an infection or a blood clot or depression or whatever it is. The more closely involved we are, the quicker we can get recovered. And so I hope that was helpful, informative, educational, interesting. I didn't speak specifically about surgeries. I think we might do that another time. And I also find that when I talk about individual surgeries like breast surgeries or tummy tucks, I usually incorporate those potential specific surgical complications to that surgery in there. And sometimes it's a large enough category that we'll talk about it entirely on its own, and we will. But I just wanted to give an overview of the common and not so common complications excuse me, adverse events that can occur after plastic surgery and specifically cosmetic surgery. So I thank everybody for their attention, and if you liked this video and you think that somebody might benefit from it, it'll be on our Facebook page shortly, and it will be on my website shortly as well, so you can refer to it there and share it with others who you think might benefit. Thank you very much for your time and attention. Have a great day.